Never let it rest till your good is better and your better is best. Good morning, one and all. With the pandemics, our lives and attitude has changed dramatically. So we need to adapt ourselves to this virtual webinar session under the special circumstances. It's a glorious moment to extend my warm wishes on the behalf of the Department of Conservative Dentistry and Endodontics, Surinan College and Research Institute. I, Dr. Soumya, under the guidance of our respected HOD ma'am, Dr. Neetu Jindal ma'am, and Professor Dr. Renu Agarwal ma'am, hereby convey my heartfelt Smita Singh ma'am, who is going to enrich us on the topic making adhesive bonding and direct composites easy. Now, I would like to hand over the periodic session to Mr. Shivam Sahai, Marketing Manager, Money Company, who is going to sponsor today's webinar session. Sir, please.
Thank you, ma'am, and a warm welcome to one and all. To start with, first of all, on behalf of Team Money, I would like to thank the entire team from Surendra Dental College, Neetu ma'am, Rajni sir, Renu ma'am for helping us in associating with us and conducting this workshop. To all the attendees, those who have taken out their time today to attend this workshop. And yes, a very warm welcome and a big thanks to Smita ma'am for sharing her experience today with all our attendees. So I'll just quickly share some update about what Money Company is, and then we'll move on with the session. Just a second. Great. So talking about money, money was established in the year 1959, and since then we have been producing high-grade medical instruments for dental treatments, for ophthalmic procedures, and general surgeries. And we've been providing these instruments across 120 countries worldwide. The main founder of our company was Mr. Masao Matsutani, and it was from his name where we took the first two letters and the last two letters to form the name of the company, Money. Moving to the number, the all across the globe where we have our factories, the main headquarters is in Money Incorporation, Japan, and then there's the list of the other subsidiaries that we have around along the globe. And the latest addition to this list is Money Medical India Private Limited, based out of New Delhi. These are the glimpses of some of our offices and factories across the Asia Pacific region. This is the main Many headquarters, and these are the factories from which the world's best class instruments are made. Coming to Money Medical India organizational chart, we have our president, Mr. Shingo Kuriyama, who heads the operations in India. And then we have our vice president, Mr. Ritesh Sharma. And then we have our very efficient sales team spread across the country and support function team would make sure that we are able to cater all the needs of all our doctors across the country. The best quality in the world to the world. This is the business policy that Money has always followed since its inception, as we believe that everyone in the world deserves the best and we are capable of delivering it to every corner. We invest 9% of our sales revenue into R&D continuously, and we take pride in more than 433 patent rights. The different divisions that that Money manufactures its medical instruments in are surgical, eyeless needle, and dental. The list of surgical instruments that we prepare are ophthalmic knife, ophthalmic switches, skin staplers, vessel knife. The eyeless needle that we prepare, these are one of the patent technology that Money has to create a hole on the top of a needle. This is the small needle, if you can see, which is less than 140 micron in size. So that is the kind of technology that Money works with. Coming to dental instruments, we have our rotary instruments, which are our diabers and rotary files. We have our retreatment instruments, which are GPR files. Then we have dental switches with which will be launched in India pretty soon. And then our hand file segments. All Money factories and offices are ISO certified and FDA and CE registered. Countermeasure against counterfeit products. Now, initially, when money came in India, we got to know that there were a lot of duplicate products that were selling in the market. To subside the sale of those products, money has been taking countermeasures against it on all platform. We've been running these awareness programs through our workshops, informing doctors who are our authorized channel partner and from where they can purchase the original product. We've been working along with the government to make sure that these duplicate products, do not enter our country and they are stopped at the port. And along with that, we have given these check filter. This is one check filter which has two sides. One is to check the authenticity of a diaber pack, and the other one is to check the authenticity of a file pack. Now, this check filter has been given to all our authorized distributors, and whenever you place your order from an authorized distributor who's with money and he's hand delivering the products, you can ask him to bring along this check filter. From the diaper card, what you need to do is that if you see the back of the diaper strip, there'll be a silver strip that will be placed on it. So when you see that strip beneath this filter, the text OK will appear on it. In a case of duplicate pack, it will not come up. Similarly, when you see a pack of file, at the back of a pack of a file, you see a money logo on it. When you see that logo beneath this check filter, you see the color of the filter changing corresponding to the color of the filter, which is red will have the red side and the green will have the green side. In case of a duplicate pack, that will not happen. We do have a website available, which is money.co.jp and /en. You can go to this website, you can check all the products, you can get their detailed information from there. Along with that, we are also available on social media. These are our handles for different channel. You can like and follow these pages, as these are the pages where we keep on regularly updating our product details, and whatever webinars and conferences money will be participating in, that all information is also shared in here, so you can keep yourself updated with those information. Just a quick glance about the new products that money has launched in the market. These are the depth marker diabers that money has launched. They come in four shapes: 103, 105, 303, and 305. These are in the diameter of the working portion is 0.3 mm, and these can be used for preparing guide grooves during your veneer preparation. We have launched up our wide range of contra-angle diabers. We have our long shank carbide burrs, which are available in 25 and 28 mm lengths. And then we have our metal carbide cutting burrs. And this is the list of all other team members, those who are spread across the country. You can note down these numbers and post the session if you want any further information about our product, you want to know the channel partner, authorized channel partner in your area, or you want to place your order. You can contact any one of them based on your respective region, and they will help you out in getting all the informations. With that, I would like to thank all the attendees for their time and hand the mic over to Dr. Soumya. Thank you.
Good morning, everyone, and heartiest welcome to Smita ma'am on behalf of whole Conservative Department and Surendra Dental College. Now, I would like to brief about ma'am. Dr. Smita Singh is graduated from King George Medical College, Lucknow, and obtained her master's degree in conservative dentistry and endodontics from the same prestigious institute. Ever since, she has been involved in academics, research, reviewer, PG training, and PhD program, and is well known in dentistry and endodontics. She is an astute clinician and is in private practice at Udaipur Dental Clinic for more than 20 years. Ma'am has numerous publications and research articles to her credit. She frequently conducts workshops and delivers lectures on restorative dentistry and endodontics across the country and abroad. Ma'am has been awarded as Legendary Lady of Modern Dentistry and received many awards of honor by Indian Dental Association. She has received many international, national, and state level awards in the field of dentistry. Ma'am has been awarded for her oratory skills at various platforms, even by ex-Vice President of India. She has also written a weekly column in leading newspaper Dainik Bhaskar on social and women's issues. Now I would like to request ma'am to enlighten us with her knowledge. And participants, I would like to request you also, if you have any queries, then please write it in the chat box to Dr. Soumya Chan. Thank you, ma'am. Please, ma'am, carry on.
Thank you so much, respected seniors, my colleagues, and dear friends. Good afternoon, good morning to one and all. I bring my greetings from Udaipur. First of all, I would like to thank Surendra Dental College Management and Conservative Department, Dr. Neetu Jindal and her team, and Team Money for giving me this opportunity to be a part of this webinar. A special thanks to my beloved students, Dr. Rajneesh and Dr. Renu, for organizing this fabulous show. I'm privileged to be giving this lecture for Surendra Dental College for the second time. I think the first lecture we had was 5 years back, and after that, this is the second time that I'm here with Surendra Dental College, and should I tell you that it's such a wonderful experience having all my students, most of my students here, and to see them grow and shape in such good humans as well. First time when we did for Surendra Dental College, then we did for the Department of Prosthodontics with Dr. Shashikala Jain, and that time also it was a very grand show that in my lifetime I have done hands-on with almost 180 participants in one day in Surendra Dental College. So that was really a record, which at least in my lifetime I have done, because usually the hands-on participants are not more than 50, 100 maximum, but for 180 participants doing it on the same day, same time was really difficult, but we did it in many rounds, and we were able to achieve our target, put our point home in the minds of the participants. So this time also, it has been really difficult, my dear friends, to make this presentation, because we have undergraduate students, interns, postgraduates, staff, private practitioners. So I have tried my best to keep this simple with lots of clinical tips, and that will help everyone in day-to-day practice. So today, we will discuss the correct application of bonding agents, which composite to be used in which clinical condition, the failures associated with composites, and how to overcome them. I'm sure that together we will achieve it. So yes, knowledge shared is knowledge gained. I am Smita Singh, and I am really honored to be here amidst such an august gathering. Thank you, my dear friends, for giving me this opportunity. Today, we will be talking about adhesive bonding and direct composites made easy. So first of all, when we use direct composites, what are the contraindications for using direct composites? If there is a high decay rate or high Cavities index, do not use direct composites. Whenever there is a large class 2 restoration where proper contacts are difficult, go for indirect restorations, they work well. Whenever your margin is in deep subgingival or on cementum, then there is a contraindication for composites, because composites leak like sieves. they leak so much on cementum. So GICs and indirect restorations work best here. For cementum, it is best to either use RMGIC or glass ionomer cements to give the best bonding with cementum. Do not use composites. In heavy bruxers, do not use composites because that will wear out the composite very soon. So when we talk about preparation designs for composites, then excising the decay only is the state-of-the-art preparation. You need not make a GB Black's cavity preparation to create a dovetail into the healthy tooth structure. There is a big no-no for adhesive restorations. So just excise the decay and you are done. And yes, you have to give bevels wherever necessary, and you are done with composite restorations. So in fact, the recent studies advocate that keeping the undermined enamel also works sometimes because the catch is enamel. So try to preserve as much as you can. I have been told that there are many students also attending this lecture. So a very important tip for you. You are taught in dental school, all of us are taught in dental school, to first check the occlusal contacts with the articulating paper to see where the stress falls and to keep these high stress bearing areas out of cavity outline if possible. But we forget this. If we actually design our cavities keeping this in mind, the restoration failure chances are minimized because then you know where the stress falls and you can omit your cavity designing in these stress bearing areas. And I will tell you one thing with my experience that this works so well that the failure rate of composite restoration just goes down. So try this whenever you start your cavity preparation. First, check the occlusal contacts, the high stress areas, and then likewise design your cavity preparation. But if the decay dictates, then you will have to extend your cavity in the decay if it comes in the stress bearing areas. But if you can avoid, do avoid. So always give beveled interproximal line angles for composites. Mechanical retention is not needed, but just in case if it's a very big cavity, you want to roughen the area, give a little bit of mechanical retention, it's fine. Do not extend into self-cleansing area, just like you do for silver amalgams. What is adhesion? Adhesion is the force of the intermolecular attraction that exists between molecules of two unlike substances when they come in contact intimately. For good adhesion, close contact must exist between the adhesive and the substrate. And the substrate here is enamel or dentine. So this means that the surface tension of the adhesive must be lower than the surface energy of the substrate so that it can wet the surface intimately. Can you change the adhesive? No. Then what can you change? You can change your substrate. You can change the energy of your substrate. So the take-home message is that teeth should always be pumised before bonding so that the surface energy increases of the substrate. Bonding on ground tooth surface increases bond strength. And this is really interesting because I have seen many people not even touching the surface and going ahead with the bonding and composite procedures. Your restoration will fail after some time because composites give best result when they are bonded on ground tooth surface. At least roughen the surface before doing your restoration. And if the whole restoration is in enamel only, then total edge techniques work really well. You need not ground the surface, or with self-etch also you can achieve your target. But whenever your preparation is in dentine, remember always to roughen or to ground the tooth surface. Proper isolation in rubber dam is a must. But if you are not using rubber dam, then cotton roll isolation and whatever method you want to do, which you are adapted with, go ahead and do it. But isolation is necessary. Bonding should be carried out in sound tooth structure only. Please remove all caries, remove all infected dentine, preserve as much as possible enamel on cavity margins, and make sure your curing light is effective. Because many a times we keep on doing our work and we forget that this curing light probably is not delivering the way it has to deliver. The intensity of the light reduces with time, and you really don't know which wavelength is it working on, and the materials that you have are initiated on which wavelength. I will talk about this in the later half of this session. So the take-home messages: to prevent oil and water contamination from three-way air-water syringes, oil filters and drying devices are placed before the air syringe, which should be changed frequently. You can ask your person who deals with your chair to install drying devices, and he will do that for you. And so the moisture coming out from your three-way syringe or the oil coming out from your three-way syringe will be shut. So for my friends who are using total etch technique, this is a special tip for them. How to etch. So friends, the recent advancement for enamel etching time is 15 seconds. Do not etch the enamel more than 15 seconds. And for dentine also is 15 seconds. Previously we were taught, and there is still a controversy, but the most recent studies advocate that when you etch dentine for 15 seconds, the dentine demineralizes to 4 micrometers. And the bonding agent also just fills this 3 to 4 micrometers only. But when you etch for 30 seconds, the dentine is demineralized for 7 to 8 micrometers, and the bonding agent fills only the 3 to 4 micrometers, which means that 3 to 4 micrometers remaining unsealed dentinal tubules permit dentinal fluid flow during thermal and tactile stress, which in turn stimulates nerve fibers in the pulpal tissue. This stimulates the primary cause of post-operative sensitivity, and the patient experiences it when eating or drinking hot or cold food, or when simply biting on restored teeth. So always remember to etch only for 15 seconds, both for enamel as well as dentine. For self-etch adhesives, this problem does not hold any importance because the demineralized dentine is filled by the resin adhesive at the same time. So I would like to bring a pointer here. So the evolution of dental adhesion based on the treatment of smear layer. Whenever the rotary instruments cut dentine, smear layer is created, which is 1 to 5 microns thick. It has hydroxyapatite crystals as well as partially denatured collagen, both of enamel and dentine. The evolution of dental adhesives is based on this smear layer. Now, the earliest generations of adhesives tried to chemically stick to it, whereas the 4th and 5th generation adhesive systems recommend removing it, and the latest generation, that is 6th, 7th, 8th, and now the 9th also, systems incorporate it into the bond. So let's see what happens when you are using total technique. Then the dentine etching needs to be done in a right fashion. So what do? When you apply, we are talking about the total etch technique, wherein you etch enamel and you etch dentine. In selective etch, you etch only enamel, but you don't etch dentine. So, and you use self-etching adhesives so that they can bond to enamel and they can etch and bond to dentine as well. So when we are talking about total etch technique, then what do you do? What is the right way of doing it? Because if you are using this, then knowing the right way would be a help. So when you apply etchant and rinse it after 15 seconds, I told you that the etching time is 15 seconds. There is moisture in collagen strands over here of dentine, which floats it like noodles. Now, if you blow air vigorously on dentine and enamel to see the frosty appearance, because we've been taught like this, that blow hard air to see the frosty appearance of the enamel and dentine so that you know that you have etched well. That is wrong. Then when you try to blow air onto enamel, not much harm is imparted to enamel. But what happens on dentine? Desiccation of dentine leads to collagen fibril collapse. This is what happens when you blow hard on dentine. The collagen fibrils collapse and stick together. Once this agglutination occurs, these fibrils serve as a barrier against penetration of primer or adhesive. So when adhesives cannot reach the exposed tubules, they fail to seal. And again, this will lead to post-operative sensitivity. So this is properly etched moist collagen. See the noodles floating and separate. This is ready to receive the adhesive. This is how you have to use. So whenever you have to use air, blow a steady stream of air gently until the movement of the bonding agent has stopped. So remember, steady stream of gentle air until the movement of solvent has stopped. So now we come to self-etching or selective etching bonding system. First, let's know what it is, and then I introduce the money bond. So self-etching reaction in which etching, demineralization, and infiltration of primers all occur simultaneously. There is no need, an extra step of etching is gone. Smear layer and demineralized hydroxyapatite become incorporated into the bond. When you are using total etch technique and you are facing post-operative sensitivity, you face white line problems. So it is the time for you to shift to self-etch techniques because they are a little bit less technique sensitive. They are technique sensitive, but a little less. If you're currently using total etch products correctly and still having sensitivity, if your sensitivity seems to be focused primarily on posterior composites, if honestly you don't see yourself routinely using a rubber dam or where isolation is otherwise difficult, in the majority of your preparation is in dentine, and this is what I want to focus on. If majority of your preparation is in dentine and in challenging cases where you cannot reach and where you have less time and in patients who do not open the mouth very well and where chances of providing isolation, thorough isolation for a longer time is difficult, in all these cases, you can switch to self-etch adhesives. And you have to form this. This is the hybrid layer which you have to form when you do a good etching and bonding. And when you use self-etch, then you have to form this hybrid layer, which is the layer between the composite and the intact dentine. And this is the bonding area between the demineralized dentine and the composite, which is where there is only very little or no mineral and only resin impregnated collagen, because we saw the collagen noodles floating and we also saw the bonding agent, the adhesives, the primers getting into the collagen to making it resin infiltrate it and making it strong. And this is what is called as hybrid layer. So this is a breakthrough in bonding technology. This is the money bond, which is also the selective etch bond. Here, this money bond is is from Germany, and it absolutely avoids pooling effect, because we have a lot of problem when you apply bonding agent. It pools to corners, it pools to line angles, point angles, and then you can never have the strength of the first layer. And remember, my dear friends, if your first layer which is formed, the hybrid layer, if that is not strong, then remember, the first layer of composite coming on this hybrid layer will break this hybrid layer with its polymerization shrinkage. Because when you put the first composite layer on this hybrid layer, what happens? The composite shrinks when it polymerizes, and it produces a lot of stress. Where will it produce all the stress? On the hybrid layer, on the first layer, on the bonding. So it is liable to break. And when it breaks, remember, if your neve is gone, then nothing can last long. So self-etching light curing one component bonding, it is the 7th generation bonding agent with single core application. Always follow the manufacturer's instructions. Maybe the bonding agent that you use now would be instructed to use as multiple coats, but this one has to be used with single coat application. It gives the best results. It can be used in self-etch and selective etch technique. The composition is, there has to be an acid, a mild acid in your one component bonding agent, so that it can etch the enamel and dentine. Here it is the phosphate esters and the carboxylic acid esters which do this job, and they are quite mildly acidic, less than 2. That's very good, because you need an acid which doesn't really have very pH, acidic pH, to have deterioration effect on enamel and dentine. With this, bonding strength to dentine is 26 MPa, which is great, and to enamel is 24 MPa. This is with selective etch, my dear friends. And if you use total etch, I'm sorry, when you use only self etch, then the bonding to dentine and the enamel even goes higher. So with self etch, the dentine bonding strength is 26, with enamel is 24. And when you use selective etch, when you etch the enamel with phosphoric acid gel, then the bonding strength to enamel will go higher. On dentine, it will remain the same. So sorry if I flumbled a little bit. After all, we are humans. No extra etching required, so it saves time and steps of restoration. There's a short polymerization time cycle that is only for 10 seconds. And when you take this bonding agent in a click stitch, you can use it for 3 minutes. So that's a long working time that is given by Money Bond. There is no need to refrigerate it. And as I told you that there is mild etching effect, the pH value is 2 more than 2, so it does not create post-operative sensitivity. The shelf life is good, and remember always to use your bonding agents with your shelf life. If they have expired, remove them from your inventory. So now let's see how to use this Money Bond, the selective etch or the self-etch reactions. So introducing the Money Bond and how you use it. When Money Bond is applied, the smear layer is solubilized into the adhesive, and the acidic carboxylic esters that I was talking about demineralize hydroxyapatite, and now the hydrophobic resin is carried into the dentinal tubules in the exposed collagen fibrils. This also comes in contact with intertubular dentine, that means in the open dentinal tubules, as well as the intertubular dentine. Remember, after application of bonding agent, it should be left in the cavity undisturbed for at least 20 20 seconds. Read your bonding agent that you are doing, whether it tells you, the manufacturer tells you to scrub it, rub it, or leave it undisturbed. And if you are not following the instructions, you are never going to get the same strength which has been provided by your manufacturer. So remember, my dear friends, all these small clinical tips are very important to get a good restoration, a strong restoration. So this is the minimum amount of time. Now, what does this money bond do on the tooth surface when it is left undisturbed for 20 seconds? First, the carboxylic esters will etch the dentine, it will etch the enamel, and then all the resins inside this bottle will go in the open dentinal tubules, will also go into the intertubular dentine, and then this all phenomenon takes 20 seconds to happen. So you have to leave this bond undisturbed for 20 seconds so that it can do its job. And now you have to take a steady stream of air, which is applied on the surface gently until rippling of motion ceases of the bonding agent. What does this mean? That when you apply gentle stream of air on the tooth and the rippling of solvent, this is what is rippling is the solvent, and this is evaporating. You have to let the solvent evaporate so that there is no white line effect in your restoration and there is no post-operative sensitivity. When you don't do this step, my dear friends, then you are bound to have post-operative sensitivity in your restorations afterwards. So this is a very important step of 5 seconds or until the rippling of motion of solvent ceases. Now is the time that the bonding agent is light cured. With an LED light preferably, which has the light intensity of more than 500 to 1200 milliwatts for 10 seconds. So this is the correct way of applying the bonding agent. And what do we do in our clinical practice? And I have seen students applying the bonding agent, waiting for some time, light curing it. Some don't even wait for some time. So all the steps have just defied. So where will you get the strength from? Your restorations are bound to have failure. If they don't fail tomorrow or day after, they will fail after some time. So remember to follow these steps. And this is how you have to evaporate the solvents. A steady stream of oil and moisture-free air is applied until rippling motion ceases. So some few more take-home messages for you when you apply bonding agent. Sealing ability of dentine reported to be excellent with money bond. It can be taken in a click stitch and used within 3 minutes. So this working time is really a good working time. And I told you self-etch adhesives to be applied only on ground surface, not on uncut surface, so that the surface energy increases, so that the retention increases, so that the longevity of the restoration also increases. The other uses where money bond can be used is in luting, indirect composite and ceramic restorations, and repair of fractured composite restorations. If your composite restorations are fractured, then this does an excellent repair. And since I'm using it for a long time now, so I can tell you that it has really good results. So the 7 mortal sins of adhesive technology which you will not do is: number 1, disregarding the directions for use. Always remember to read the manufacturer direction before you open your bottle, before you open your composite, before you open any material that you have bought. Contamination. Do not use in case of contamination of cavity with blood, sulcus fluid, or saliva. If after applying bonding agent and you see, many a times we see that the contamination has taken place. We can see the gingival fluids seeping in. Still, what do, friends? We take the 3-way syringe, blow air, and go ahead with the procedure. Don't do that. I know that you are short of time. I know that many patients are waiting, but that does not mean that we will do steps in a wrong fashion. there should be a flame in our hearts to do whatever we do in the right manner. Overetching, do not do that. I told you that what results we have for overetching. Mortal sin number 4 is over drying with a blast of air or dentine dehydration. Please do not do that. Mortal sin number 5 is insufficient rinsing after dentine conditioning. That is, if you are using total etch technique, wherein you apply phosphoric acid gel both on enamel and dentine, then do remember to sufficiently rinse it so that all the phosphoric acid gel has been removed from the enamel as well as dentine. No usage of expired material. Yes. Mortal sin number 7 is insufficient amount of adhesive. So always remember to apply a bonding agent copiously. Apply it copiously. It's a single coat application, but copious amount should be taken. Remember your painter's advice, how he paints your walls. So apply in the same fashion. Now we come to the art and science of various direct composites. After completing our bonding system, now we have so many composites in the market, packable, flowable, then microhybrids, nano composites, bulk composites. There's so many. I have made this presentation simple to tell you which composite should be used in which clinical situation to give the best result. So selection of composite, two properties of dental composite that most clinicians evaluate are mechanical and aesthetics. Either you want it for posterior teeth or you want it for anterior teeth. So when you use it for posterior teeth, it should give you strength, good bond strength, and adhesion as well. And when you use it for aesthetic properties, then it should give you a good finish and polish with a good shade matching. So handling of composites should be done in such a way that they should not slump, tear, pull, or stick to instruments. Because many a times it is so frustrating that your composite will not stick to the tooth, but it will stick everywhere else. But where it has to stick, it will not stick there. Why does this happen? This happens because your instruments are contaminated. Because we have a habit of using the same instrument, handling the glass ionomer cement, handling the same instrument with cement restorations or miracle mix if you do, and handling the same, with temporary fillings. So when you have one instrument and it works everywhere else, then what happens? Your dental assistant, when there is any glass ionomer cement or miracle mix stuck on the on your instrument, then what does he do? He doesn't know the correct way of removing it. And what he does is he scrapes it out, he scratches it and removes it with his nail, with another instrument, with a sharp probe. And so there are a lot of irregularities which form on your handling instruments. And so this is the problem, that they are contaminated, they accumulate a lot of dirt, and so your instruments do not work well with composites. So remember to have separate instruments for composites. Do not mix it with using handling other materials. So higher quality composites have shortened chair time, and far fewer failed restorations and redos. So remember to use them. Select high quality composites and use them. When we use low quality things, then we do not get a good long-term, we cannot guarantee a long-term prognosis for them. I do not mean that you do not buy simple things or cheap things, but what I want to say is that you should have a thorough history of whatever product that you buy and use. So thorough cure also greatly contributes to the longevity of a restoration. Remember to cure your composites well. Curing light, I have talked about this in detail in the end. And that is really something which I have done with my heart, and I hope that you will like it also. So curing light, which easily cures all photoinitiators, no matter where they are located in the mouth, should help ensure restoration, durability, and longevity. Because if it's a big restoration, then remember the composite is full of photoinitiators here and there, everywhere they are. So your curing light also has to reach to all the photoinitiators to start generating the free radical. Now, accurate shade guide, no guesswork out of shade matching, should be a predictable, straightforward experience. Now, when you want a composite, then you have to take that, you should have a composite which has a full inventory of aesthetic results, which means higher range of options determine how lifelike and finely detailed and aesthetic the final result will be. So if the opaque shades, you have chosen the opaque shades, the dentine shades, that will normally establish the hue and chroma of the restoration, whereas the translucent or the enamel shades will determine the value or overall brightness of the restoration. You should have all these shades available if you want to give a good aesthetic result. Now, the opacity of the dentine shade in combination with translucency of the enamel shade will give you the best aesthetic results. But when you need to repair only a small chip or a defect, then single shade is more than enough. But if you need it for a very complex restoration, then multiple shades, you will have to use multiple shades, especially for anterior teeth, where we select a lot of shades before giving a lifelike appearance to the tooth. I am although not going to talk about all that today, but sometime we will talk about it if I do get another session with you sometime. So this is when you give multiple shades, this is the result that you get. You get translucency, you get opaqueness, you get whatever you want there. In the dentine, in the enamel, on the top of the layer, giving details, finer details to the tooth. So your composite should also be versatile. It should perform well in anterior as well as posterior restorative case, so that you know, now we have composites which are in so many, available in so many shades. So there is less inventory, because you don't have to keep so many shades, something for anterior restoration, something posterior restorations. So less inventory is generated and therefore less expired materials, because we go anywhere, we buy a lot of things and come back, but do we use them? They are lying in the almirah, that one day we will use it. That one day never comes. So do not generate a lot of inventory. Whatever you have bought, use them and try to be smart in choosing your composites. So that is true, that facing the change can change everything. And this is what I believe and what I work on, is the only person you should try to be better than is the person you were yesterday. And always compete with this person only. Do not see your friends. Do not see who stands where. Just see yourself. Compete with yourself. And my dear friends, you will never be jealous. You will never be dissatisfied in your heart. So microhybrid composites. Microhybrid composites, if you choose microhybrid composites, then why do you choose them? What are the indications of choosing them? They closely simulate the dentine of natural tooth structure, because microhybrids have got a lot of opacity in them. So they replace dentine very well. They have larger particle size than nanofills and microfills. And because of their higher strength and greater opacity, microhybrids are perfect for supporting the high stress bearing areas. And since they are opaque, they are also great for masking out unwanted color or achieving extreme color changes. So whenever you want extreme color changes, these are the composites that will help you. So Money Micro is a great microhybrid composite. It can be used both in direct anterior and posterior restorations. Your inventory is less. Indirect restorations such as inlays, onlays, and laminate veneers also, because it has a very good strength. It It can also be used in fissure sealings in molars and premolars, can also do stump buildups and splint loose teeth, adjust the contours and shades to improve aesthetics. So it can do almost all the things that are required in your oral cavity with composites, and it also has a very good compressive strength, that is 403 MPa. What do you say about this? This is a very good compressive strength for composites. And why does all this happen is because it has ultra-fine radio-opaque glass fillers, and so that is why they are they can be handled aesthetics. And in fact, it's such a good aesthetic restoration that you know your I think my internet is getting unstable. If I lose you, please do let me know. So this also ensures very high luster and homogeneous surface, and in fact it is a composite that has been placed as labeled as being very gentle on gums. Very gentle on gums means that there is very less irregular or rough surface. And where do you need this smooth surface? Tell me, friends. You need it on the cervical areas. So when you do class 5, whenever you finish and polish your composites, don't you feel that, oh, it's still rough? So these are composites which are very gentle on the gums because they do not gather plaque. They give you a very smooth layer on enamel. And also one more thing, that they have very good improved fluorescence, and this is what you want if you are doing your anterior restorations. So they give you a good fluorescence as well, and they are extremely plaque resistant, give very smooth surface. Now they are available in a variety of shades, and they also come in universal shade. If you want only one shade, that is also available. The curing time is 40 seconds, working time is 2 minutes, and for a 2 millimeter increment. So remember, you have to take this no more than 2 millimeters, a 2 millimeter increment to be taken for Money Micro, cure it for 40 seconds, and the working time that you get to work with this material is 2 minutes. If you are going to use it for more than 2 minutes, if your placement is such that your restoration is too big and you feel that it's a complex restoration, then always remember to put off your light in other direction so that it may not set with the light may not interfere with the setting reaction. So this is a result that you can get with microhybrids. Now, nano composites. Where do you use them? The nano-filled resin composite was found to have less polymerization shrinkage. And should I tell you, the polymerization shrinkage of composites is reported with all composites to be between 1 to 6%. And this is the most frustrating thing of composite, this feature of composite, which leads to so many problems. I will talk about them later. So the best thing, now you remember that nano composite was launched because of its low polymerization shrinkage, that is only 1.66% as compared to the microhybrids. And these nanofillers are situated very close to each other to protect the softer resin matrix from abrasives, thus increasing the wear resistance. So whenever you need any composite that has to be wear resistant, also because I told you not to use for bruxers, but if you cannot give metal restorations, or if you cannot give indirect restorations for any cause, the patient is not financially strong, you want to give a low budget restoration, then remember to give nano in such cases. And also remember, because they have low polymerization shrinkage, so the chances of marginal straining, the chances of micro leakage, all this will be reduced. So Money Nano is a product which I really like, is because it does not need any inventory for composites. You can take this product and use it in anterior, posterior areas, in for giving strength, for giving plaque resistant features, and also using it anywhere you feel like and giving you the best results. It also has a variety of shades available, and that is why you can use it almost anywhere. Stability to ambient light is 3 minutes. For micro, it was Money Micro, it was 2 minutes. And here the stability to ambient light is 3 minutes. That is, you can work with this material for 3 minutes. We have to understand every line which the product says to give the best result with the product. And that is why I am elaborating it so much. I know that you do know about this, but for my friends who may not be knowing this, it is for them. So Nano Composites, here this Money Nano uses real nanoparticles, that is 15 to 20 nanometers, and that is why it gives such a good homogeneous mix, and so it gives a very good homogeneous result on enamel and dentine. The compressive strength is 432 MPa, which is more than microhybrids. So, but remember, my dear friends, when you want opacity, when you want extreme color changes, then microhybrids will help you. And here in Money Nano, what you need is wherever you need good strength, wherever you need great luster. So in anterior posterior restorations, you can give Money Nano. The depth of cure is 2 millimeters. Remember to place it in 2 millimeter increments only. What I want to emphasize now is it has such a great amount of filler, the highest filler content of all the composites, and that is 83.5% by weight, which is really a very good filler content. Jitna zyada filler content hoga, polymerization shrinkage will decrease. So the polymerization shrinkage is therefore very less for them. They have a very good longevity for restorations, and they can produce natural looking restorations as well. They come in a lot of shades: dentine, opaque, translucent, apart from that white, that is bleach shades. So a whole inventory is there with all the shades possible. So in your kitty, you have all the shades, plus you also remember that there is a good shelf life, that is 3 years. So if you buy them, you will not require any other material to buy as well. The polymerization time is 20 seconds and 2 millimeter increment should be used. So 2 millimeter increments cure it for 20 seconds, whereas in micro, we have to cure it for 40 seconds. Remember the curing time which is given by your manufacturer, because if you undercure, if you overcure, it will not have a very hazardous effect, but if you do undercure, my dear friends, then that will lead to failure. So this is the lifelike appearance that you can get with Nano Composites, the Money Nano. Now the flowable composites. Where should the flowable composites be used? The advantages are high wettability of the tooth surface, so it ensures penetrations into every irregularity, ability to form layers of minimum thickness, so improving or eliminating air inclusion or entrapment of voids, of air bubbles. And this is a very big problem till today with composites, is that in between the layers, there is air voids. You entrap air bubbles. If you do not use flowables well, if you do not handle the flowables well, then there is a lot of air bubbles entrapped in them. But with this flow, which I'm going to talk about, you hardly can entrap any air bubbles in them. So it has, flowable also has very high flexibility, so less likely to be displaced in stress concentration areas. So wherever there is stress concentration areas and where you need flexibility, that is of course in the cervical abrasions, when you do class 5 restorations, The liner or base should be with flowables to give you the best flexibility as well as the best placement of the composite over it so that they can serve you for a very good time. The longevity of the restoration increases. Radio opaqueness and availability in different colors. And the product that I'm going to talk about is Money Flow V. That is the flowable composite, right? Flowable composite you've heard about. But if your flowable composite is also viscous, that is where you want your flowable to stay put, it stays there. Because what happens with flowable composites, my dear friends, that they keep on dripping, and where you have placed them, they are never there. They are somewhere else. So because of their ability to flow, they can go to any area. Perhaps you don't need your flowable to be reaching that area, but it is almost everywhere. So if you want your flowable to stay where you want it to be, then this viscous flowable or the Flow V is a grand choice. This material is flowable as well as viscous when necessary, so it adapts nicely to the cavity walls. And ideal flow characteristics simplify the restoration. The filler content is 77%. By weight, you should always see that which composite you are using has what kind of filler content. So the filler content is good, and the tensile strength is excellent, 46 MPa for a flowable viscous, and the compressive strength is 431 MPa, which is really good, really good. And depth of cure is 2 millimeters. So remember that Flow V has to be taken in an increment of 2 millimeters, not more than that. The radio opacity is 210%, which means that you can see, in fact, with Money, all composites are radio opaque, having this percentage of radio opacity so that you can appreciate them on the radiographs. How frustrating it is, my dear friends, to see a composite restoration on a radiograph which is invisible. You can't even appreciate how deep that composite restoration is and what should be your treatment plan with this tooth. So it is always advisable to select a composite which is radio opaque. It comes in a variety of shades, comes in a very huge shelf life, that is 4 years. It's a good time. Polymerization time is 40 seconds for 2 millimeter increment. So remember these little tips, that what your polymerization time should be and how much increment you should be taking. So this is a case of pit and fissure sealing done with Flow V. Preoperative and post-operative. So it has optimal flow properties, which I want to emphasize on. It is excellent for class 5 restorations, no running or dripping, easy and highly precise application. Even penetrates into areas that are difficult to reach, no void formation. And the best part that I like about this product is it does not keep extruding as rest of the flowables do. Now, how to properly manage polymerization stress with bulk composites. So where should we be using the bulk composites? Because this is the most recent advancement of composites, and not very recent, but since it has been introduced to dentistry, it has been in the limelight or by some way or the other. So this is Money Bulk, which is a bulk film composite. All the products are made in Germany and have Japanese standards. So the best standards, because both the names, the German as well as the Japanese, are known for their technology. They're known for their advancements. They're known for their, for the finesse of materials. So this Money Bulk is a posterior restorative material to create posterior restoration simpler and faster. Provides excellent strength and low wear for easy and fast handling in bulk fill techniques, and this is both flowable as well as viscous, just like the Flow V. But what is the difference? The differences are many. First of all, the depth of cure is 4.5 millimeters, that you can take it in an increment of 4 millimeters. And that is why this makes your life simple, is that you can just take 4 millimeter increment and cure it. And if you want, you can top it up with a nano composite, a microhybrid, whichever you feel like. So to give you the color of the restoration also, and the bulk is given by money bulk. Because you can use it. Have you ever thought that why do you use bulk composites you can use it in a 4 millimeter increment? Is because that they are translucent. And because they are translucent, they permit the light energy to go inside into the deepest layers also, so that there is generation of free radicals and there is generation of polymerization. So when you have 4 mm increment in a translucent shade, and if you want to give an aesthetic result, then you will top it up with a money micro or a money nano. Otherwise, you can leave it as it is. It can be used as a liner or base also, these money bulk. It has a shelf life of 4 years. That's good. The polymerization time is only 20 seconds for a 4 mm increment. So this makes your life simple. Now, the take-home message is that bulk fill composites are more translucent than other restorations, which allow the light to get to much deeper layers. The content of photoinitiators of polymerization, they determine the optimal marginal seal of these composites. So my dear friends, what I want to emphasize is that if your initiators have been activated by the light cure, when you are using it properly, then there is a lot of free radical generation, and this free radical takes care of the complete polymerization, and so does give a good marginal seal as well. So the bulk fill flowable composite resins possess a lower modulus of elasticity as well as lower levels of polymerization stress in comparison to traditional flowable composite. This is what I wanted to emphasize, that your traditional flowable composites give a lot of polymerization stress to the tooth, whereas the bulk fill have very lower levels of polymerization stress without compromising on depth of cure. So and how do you actually do it? I still do this, even though I have a feeling of my cavity depth and all that, but still to be very consistent, I still measure the depth of the cavity if it's a deep cavity with a periodontal probe to ensure that the manufacturer indications of 4 millimeter are not exceeded. I am going to now introduce a very interesting incremental technique. And because I know that there are many of students, I want you to inculcate this habit when you start doing composites, and for my interns and for postgraduates. Also, I want you, if you are using this, it's great. If you're not using it, then inculcate this the habit, and your life will become simple. So this is the vertical incremental anatomic, which is also called as the anatomic technique in class 2 restoration. So I'm going to do this with money bulk, and that is why this is here. Because I was talking about money bulk, so I thought why not to show you cases also to know how to handle it. So in vertical incremental layering, the same number of increments are required as horizontal as we do it generally. We place an increment, on top of that we place another increment, that is the horizontal layering. So in vertical incremental layering, the same kind of technique, the increments are the same, but the placement of the increments are different. So 1 to 3 millimeter increments are buttered against wall, and here what we do is that we do not connect opposing walls. So the C factor stresses are minimized. What is C factor? I will tell you now. So because of its more anatomic placement, it follows the contours of cavo surface, and there is less post-operative adjustment. So what is a C factor? C factor, my dear friends, is a ratio of bonded to unbonded walls. Needless to say, tell me, in which class of restorations will you have the maximum C factor? that is class 1, because there are 5 bonded walls and 1 unbonded. Whereas you hardly see any post-operative cases in sensitivity in your anterior restorations, the class 4, because the C factor is only 0.5. Because there's a lot of free surface area for the composite to release its stresses. And so the same concept is going to be introduced in this anatomic placement. So when you place horizontal increments, what happens? It's the composite in between, and the tooth wall is here, the tooth wall is here. So both the sides, the composite is attached to the tooth walls. And so when it polymerizes, because of the polymerization shrinkage, there's a lot of stress, that polymerization stress that is induced in the composite at that time. So what does it do? It imparts this strength to these walls. And this is what causes a lot of stress to the tooth walls, so much so that sometimes your walls may craze or fracture. You can see craze lines, fracture lines, or it may also fracture. The restoration will fracture. That means that the stresses are so much that your restorations can fracture. And if you can avoid this, why shouldn't we? So using vertical incremental layering, you create a large free surface area with each increment because you have not connected the walls. So every increment has a large free surface area to release its stress. And then you put another increment. This also has a large free surface area to release stress. So this is how you incrementally build your tooth with vertical increments. So I'm going to show you a case with of a posterior restoration with money bond, money bulk, and money nano. Let's see it step by step. These are the 2 molars on a model. This is, and we are going to do a class 2 and a class 1. So matrix band has been placed. Bonding agent is being applied. The money bond is applied on all the floors, the cavity walls, and the cable surface margins for both the teeth. And then we know what we have to do. 20 seconds, it has to be left undisturbed. And the amount that has been taken now is the copious amount that all your, the tooth should have a glistening effect. It should be all the line angles, point angles, the floor, the walls, the cable surface margin should all be glistening. That means that you have substantial amount of bonding agent. Now wait for 20 seconds because it has to do all those things which I told you. And now after waiting for 20 seconds, you will take a gentle stream of air and remove the bonding agent. You will remove the someone is taking screenshots. So you will remove the solvent, which is in the bonding agent, because this is also a very important step. So you will do this, and then after that, you will light cure. So this is the whole procedure that has to be applied. And now, what I will do is that I have taken money nano, and I have made this proximal wall with money nano, light cured it, and removed the matrix band, which is that I have converted the class 2 cavity into a class 1. And when I do this, my life becomes so simple. Now there is no retainer, there is no band. So your light cure can also go to the buccal and the lingual area where you want your light curing material to be, cured very well. And similarly, the light can go in all the surfaces of this tooth unhindered. So I like always converting my class 2s into a class 1, removing the matrix band retainers, and then filling this class 1 in with a vertical incremental technique. So I have started putting the increments of, and this is how light cured. See, with my money bulk as the base, I am putting money nano to give vertical increments and carving it at the same time. You can produce fissures, grooves You can give all the anatomy at this time only, at this stage. So there is minimum post-operative adjustment. The composite being placed on top of the money bulk in a vertical incremental fashion. And see the luster of money nano when it has not even finished or polished. When it is not, I have not even finished and polished, and see the luster. And after finishing and polishing, this is the luster. So just see the results with money bulk and money nano. Now the centripetal technique, which is a class 2 technique again, just to give you an idea of vertical incremental. This is a silver amalgam restoration. Removed, cleaned, the cavity is inspected, the matrix band being placed, wedge being placed, retainer being placed, and after that, bond it well, make the proximal margin with composite, money micro or money nano, remove the matrix band, remove the retainer, and now take your light cure probe into these angles, because you know this, that the composite shrinks towards light, and when you want your composite to shrink towards light, then it will seal this margin. So also remember to keep your probe in such a way that when the composite shrink towards light, it seals the margin. Do not keep your probe in another direction like this and cure it. Otherwise, your composite will pull off from the margin. So these are little tips that you have to remember while doing the light cure restoration. And see, after finishing and polishing, this centripetal technique is done with vertical incremental layering. Because of distance from curing light to composite on gingival box, the light intensity drops significantly, resulting in inadequate polymerization. After removal of matrix band and retainer, light curing can be easier for all increments. And this is what I was talking about, that take your light cure probe in all the areas and just light cure it, so that from top of it, the light intensity probably will not fall in the same intensity as it is on the surface. The light intensity drops as the depth increases. So if you take your light here and here, your light curing free radical generation can be complete or more. It can never be complete, but it can be definitely enhanced. So now, reasons for failure of composite restorations. Why do our composite restorations fail? That is, first of all, I'm so happy to see so many participants, and you know why I'm happier is because none of them have left. So this is really so touching, and this has really touched my heart. Thank you so much, my dear audience. Thank you for being there. And this is my effort, just in one direction, to make your life simple with composite restorations. So reasons for failure of composite restoration is disregarding manufacturer's instructions. If you don't follow the manufacturer's instructions, we've talked about this in detail. Reasons for failure of composite restorations is effectiveness of moisture control when you do not use rubber dam, or when you do not isolate the procedure well. Just the main thing is that whichever way you are well adapted with isolation, you should do that. Shade matching, finishing and polishing should be in proper fashion. Otherwise, again, you will lose your restorations very early. Secondary caries. That is, we are talking about the failure of composite restorations, and secondary caries is one of the reasons. You know why? This is because of polymerization shrinkage playing a very big role. And now you know that your light cure probe also plays a very big role for making this happen, for marginal leakage to happen. The marginal deficiencies The polymerization of composites and formation of a cross-linked polymer bring a volumetric change of 1.5 to 6 volume%. These are the stresses from shrinkage which create forces that compete with the adhesive bond. And I told you that they compete with the adhesive bond. They try to fracture and fail this hybrid layer which you've made with your bonding agent. And so this is why I talked about the bonding criteria in so much detail and so many times so that it gets registered in your mind. And this is the polymerization shrinkage is still one of the main causes of marginal failure and subsequent micro leakage. Fracture. This also happens because of polymerization leakage, and where is because of the inherent property of the composite, like microhybrids are wear resistant, nano are better than microhybrids as in this phenomenon. So you should know which composite to select where. Now, reasons for failure. One common factor which is always present in all the reasons is polymerization shrinkage. And this is where the restorative material pulls away from the tooth, leaving a gap that eventually leads to post-operative sensitivity, marginal staining, recurrent caries, and eventual loss of restoration. So when we do incremental layering, what happens? The vertical incremental layering, as I told you, how to reduce this polymerization shrinkage, go ahead and do vertical incremental layering so that the tooth may not pull the composite from both the sides, or the composite may not, put stresses on the tooth walls. Now, placement of flowable composite as a stress bearer. Recent approaches, low shrinkage stress, as I told you that bulk fill composites have such low shrinkage stress because of the reported reduction in shrinkage stress. So use bulk fill composites wherever you feel that the cavity is too deep, is under a lot of stress, comes under stress bearing areas. Use bulk, top it with nano, money nano, or use a flowable composite, especially in cervical restorations, so that your composites would serve longer. And these flowable composites of any type are used as a stress breaker. So like in this cervical restoration, you can see with flowable, I used Flow V and then I used Money Nano. The finish of the restoration is good, very nice on the gums, no plaque resistant, and even after 5-7 years, it'll be the same. So be predictable about your restoration. Like in anterior teeth. So now the take-home message to prevent polymerization shrinkage is light curing it rightly. Always remember to have some kind of checking device in your dental office, that is a radiometer. If you can buy a radiometer, that is really a very good investment, because then you know that your light curing probes are producing what intensity. Your intensity of light curing probes now for LED, it is stated that they should be between 1000 to 1200 milliwatts per centimeter square. And the wavelength of the light that is required, because all the composites that are generated today, that are manufactured today, come in a wavelength where they have a photo initiator which gets activated in a range of 300 to 500 of a wavelength range. So if you want your curing light, always ask that what wavelength does your curing light which you are buying work on. If they work in between this 300 to 500 nanometers, then only it is some sense of buying them. And especially 468 nanometers, where the camphoroquinone usually, which is now we have so many photo initiators, but the one that is used widely is the camphoroquinone, and that gets initiated at 468 nanometers. So your light cure should be focused. Your light curing machine should have this wavelength and should also have the right intensity, because If your light cure probe does not generate good intensity, then you are just using it for no other reason. It is just the light is being produced and nothing is happening inside, my dear friends. You feel that your curing is taking place, but actually no cure is being taken place. Very little cure is being taken place, and lots of unreacted monomers are still in your restoration, which will lead to polymerization shrinkage, which will lead to marginal deficiencies at a later date. So this is what happens. This is called as the degree of conversion. And this degree of conversion is when the monomer converts into polymer. And you will be really, amazed to know this, astonished to know this, that only 64% of the monomer converts into polymer, and rest 36% is lying over there unreacted, which will lead to all these problems. And we can overcome these deficiencies if we place our light cure probes well. So when you put your light cure probe, then what happens? The first layer gets the maximum light intensity. And as you go down, suppose it's a deep restoration, and as you go down, can you believe that the degree of conversion is only 15%? Your light intensity just decreases. So remember to check your light curing unit's light intensity at all times. And always remember to put your light cure probe perpendicular to the tooth surface. Do not put it tedha. Don't put it obliquely on the tooth surface, otherwise you will be in loss. You will lead to polymerization stresses, you will lead to polymerization shrinkage at a wrong place. So I would also suggest that whenever you start your light curing, always use soft start, pulse or ramp curing, because your lights have this. The newer lights have these functions of ramp curing, pulse curing, soft curing, which means that first the softer light intensity is imparted to the composite so that it may slowly and steadily form into a polymer. And when it forms into a polymer, when the free radicals are generated, they start forming the reaction, and the monomer starts forming into a polymer. And when it forms into a polymer, it does not, go black. It goes in a slow fashion, intermittent fashion. So what happens? The stresses are not imparted to the tooth, but the stresses are absorbed by the polymer itself, by the composite itself. And then you can give the light intensity more to have fully converted the monomer into polymer. So what I mean to say is that first give less light intensity so that when the monomer forms into a polymer, the stresses that are generated are absorbed by the polymer itself, by the composite itself, and less stress is imparted to the tooth surface. And then after that, you can increase the light intensity and do the rest of the monomer conversion to polymer. So this is a very good phenomenon, and till to date, the most acceptable light curing phenomenon. So, and you have this this phenomenon in your light cure machines. If you have a good light cure machine, then you do have this. So just a recapitulation that curing time depends on resin shade. The darker composites need more curing time, lighter shades require less curing time. The composites at room temperature cure more completely and rapidly, although there are so many advancements in this also. Thickness of resin should not be more than 2 millimeters. The distance between the light and resin should be less than 1 millimeter, and the light should be positioned 90 degrees on the composite surface. If you're using microfine composites, I have not talked about them, but microfills are also there on board. So if you're using them, remember that they are very difficult to cure. So give an increased curing time for them. Light source of the light source quality should always be checked. The wavelength should be between 400 to 500 nanometer, and ensure that your intensity is good enough. And halogen lights, I think you should discard them from your dental office because they do not give good light intensity. So always it is better to invest on a LED light cure probe. And you should also know the nanometer, as I told you, the wavelength that your light cure probe works on, and also about the intensity of the light. So good investment is on radiometer. So golden tips for light curing is do not look in the blue light. You know, friends, I was amazed when I read about this article that if you look 7 times in a day, you know, when we place our blue light, sometimes the light shield is not properly placed and somehow you look at the blue light. So if you look at the blue light for 7 times only in a day, that is much enough to cause degeneration and to cause retinal damage. So if this is really true, then please do wear protective shields, eyewear, and also keep the shield of the light in a proper direction and then start the light curing. Larger diameter tips should be taken and they should be around 10 millimeters, because if you use a very small, you know, some manufacturers give small tips which are not good because they don't cover the whole surface. So you will have to place the light cure probe on all the surfaces, you know, incrementally, and that takes a lot of time. So if you have a large diameter light cure tips around 10 millimeters, that would be best, so that you can continuously cure it. Frequently monitor your light output. Faster curing lights do not always produce better outcomes. Remember this fact. Light cure tips should be perpendicular and as close to the restoration as possible. And the best tip is do your light curing yourself, actually, because when you give your assistants to do the light curing, they would be sometimes they keep it obliquely and sometimes they keep it somewhere else, probably where the intensity should reach, it does not reach. So do not let your assistants do that, do it yourself. So my dear friends, we are going to end this presentation, and those who have heard me before know that I end my presentation with this, because this is what I love and I keep repeating this to myself. I mean, not this, but the motto of this. A man feared his wife wasn't hearing well and he thought she might need a hearing aid. Not quite sure how to approach her, he called the doctor to discuss the problem. So the doctor told him about a simple test to perform. That evening, the wife was in the kitchen. He stood about 40 feet away and in a normal tone asked, "Honey, what's for dinner?" No response. So he moves closer to the kitchen about 30 feet and repeats, "Honey, what's for dinner?" Still no response. Next, he moves about 20 feet from his wife and asks, "Honey, what's for dinner?" Still no response. So he walks up directly to the kitchen door and asks again, "What's for dinner?" No response. So he walks right behind her. "Come on, what's for dinner?" I've said Matar Paneer. So the moral of the story is that the problem may not always be with the other person, with the composite, with the instrument, with the light cure, with the assistant, with the patient, but it could be very much within us. So no one can go and change a bad beginning, but anyone can start now and create a successful ending. Thank you so much, my dear friends, for giving so much of time to me. Let's paint the restorations in the right fashion. Thank you so much. Thanks a lot.
Thank you so much for a wonderful lecture, ma'am. We really enjoyed your lecture, as you have told about how to apply bonding agent, correct technique, how to apply it, and then which instrument we are supposed to use, correct handling of instruments, and which material we are supposed to use in which cavity, like nano composites, hybrid composites, flowable composites. After that, horizontal and vertical techniques, what is the difference, how we are supposed to use it, and then what is the correct use of curing lights, the distance we are supposed to take care. Thank you so much, we really enjoyed, ma'am. Now we have questionnaire round. Please, ma'am, clear our doubts.
Yes.
Yes.
Ma'am, which bonding system
Hello.
is, yes,
Uh, Thank you so much, ma'am.
thank you.
Ma'am, there are a few questions from our participants.
Yes.
One of it is if the composite restoration is breaked or fractured, then it's better to to repair it or to do it all over again.
That's a very good question. But I believe that if the fracture is just a chip, then you can repair it. But if it is in the bulk of the restoration, or if there is a marginal distortion or something like that, then it is best to remove all the restoration and do it all over again. Just a chip can be repaired, nothing more than that. Am I audible?
Hello.
Yes.
Ma'am, the another question is how should we store the composites? Whether it
How
should be
should
stored
we?
in refrigerator?
Oh, what a lovely question. I think it can be stored in room temperature, but not in those areas where you have direct sunlight falling on. And the basically all the composites have a temperature range of to be stored is 10 degrees to 25 degrees. So if you store it in a drawer or in a place which is cool enough, in an almirah which is cool enough, then it is fine with the room temperature as well. But if your clinic has a lot of light everywhere and you are keeping your composites in the sunlight, I've seen sometimes in many dental offices that the composite bonds, the composite restorative systems all are lying on top of the table, and there is optimum amount of sunlight falling on them, then that is not the right thing. Then that interferes with the nature of your composite. And my dear friends, I would like to emphasize this. Like in money products, we have to store it not in a refrigerator, but in a cool place. So you can also read the manufacturer's instructions where they are trying to tell you to store their products. But I don't think that refrigerator is really required in these products. But if your manufacturer does direct you to keep it in a refrigerator and refrigerate it, then you should go ahead with it.
Thank you so much, ma'am.
Thank
Another
you.
question is it wise to use laser lights for curing the composites?
It is, why not? Why not wise? I mean, they're so expensive. The plasma arc and the laser lamps, all of them are so, the plasma lamps and the laser lights are so expensive. You can use them, but they also produce a very high intensity. And with high intensity comes heat. So you have to take care that your pulp does not cook in that intensity and with that heat. Otherwise,
Thank you so much, ma'am.
thank you.
Thank you, ma'am. Ma'am, the another question here is that is it always necessary to remove the smeller?
Is it always necessary to remove? No, it is not necessary, and that is what we talked about. That we have so many adhesive systems now that they work on some work on smear layer removal, some work on modification. But these self-etch, in these self-etch, you do not remove the smear layer. You get it incorporated it into the bond.
Thank you so much, ma'am. The another question here is that when we are using lasers to remove class 1 cavities, do we need to do any modification in the composite restorations?
Uh, the modifications would be bevels, of course, if they are indicated in those areas, because bevels are not indicated in everywhere in composite restorations. Please check this, because in some certain areas only bevels are indicated. Otherwise, there is no need to unnecessary bevel where the composite already the cusps fall in a beveled fashion. So only these modifications need to be done after using the laser.
Thank you so much, ma'am. Is it necessary to use bond after each layer?
No, no, not at all. Because bonding has to be applied once, and after that, the first increment of the composite already has an oxygen inhibited layer, which bonds with the second increment. You know, I did not talk about oxygen because this is a little advanced. So the oxygen inhibited layer in the increment, which is there, does bond to the next increment. So there is no need to apply any bonding agent.
Thank you, ma'am. Ma'am, the another question here is Geomer comparable to nano composites or micro hybrids?
No, no, not at all. They are already another sect of materials. The properties are absolutely different, so not comparable.
Okay, ma'am. Ma'am, the another question here is like many articles say 15, 30 or 60 seconds for curing the for restoring the dentin.
Sorry, I lost you. Uh, Sorry, I lost you. I hope I'm audible. You lost me or I lost you?
Um, Sorry, ma'am, for the
Yes.
inconvenience.
No, no, no. I
Ma'am, the
started
question here is,
now.
Hanji.
Yes.
Ma'am, the question here is many articles say 15, 30 or 60 seconds for etching. So is it like in every situation we have to go for 15 seconds only, or in different in any special condition we have to go for 30 seconds or 60 seconds also?
What a nice question. Although I elaborated for 15 seconds, but not all dentine are the same. Because all this is a little advanced, so I did not incorporate this in my lecture this time. But not all dentine are the same. We have so many types of dentine, secondary dentine, then tertiary dentine, then sclerotic dentine, then so many types of dentine, and all of them require different behavior, different etching times. But for a normal dentine, it is 15 seconds only.
Thank you, ma'am. Ma'am, there is one more question. So the question here is that what do you prefer, which is better, total etch or self etch?
When your preparation is in enamel, total etch technique. When your preparation is in enamel as well as dentine, self-etch technique.
Thank you,
But
ma'am.
always
And
on
ma'am, there is
grounds tooth
another a
structure.
clinical question that. Thank you so much, ma'am. There's another question like for anterior teeth, do you prefer composite buildups after root canal treatment, or you prefer processes or crown placements? Or is it enough to go for composite
Yeah, I'll tell
only?
you that if you have not lost sensible amount of tooth structure after access cavity preparation, then there is no need to go for full crowns. You can go ahead with a composite restoration. They will work well, and they will work well for quite, for many, many years. But if there is substantial amount of loss of tooth structure, then it will be best to give a prosthesis.
Thank you so much, ma'am. Ma'am, the last question here arises is that for posterior restorations, which is better, nano or hybrid composites?
So I told you that you have to select. I gave you so many reasons where you have, lots of forces generated on the tooth surface. Nano would be better. Where you want opacity to come into your restoration, then micro hybrid, micro would be better. So these are little things that you have to judge. As I have told you in the entire lecture of how to select a restoration.
Thank you so much, ma'am. Ma'am, there is one more question arising. Here it is that during sandwich technique, do we have to etch and bond after GIC application also?
You will first etch the enamel. If you are using a selective etch technique, you will first etch the enamel and uh, then apply your RMGIC and put the bonding agent, but not after putting the RMGIC.
Thank you, ma'am. Uh, Ma'am, there is another question also.
Yes.
What's the motivation that keeps us going or get refined in this field, and the very first thought that made your mind when the ma'am this motivating the ma'am, it's like it's actually a journal question, I guess. So students just wanted to ask that, like, composites, we should go for composites in most of the cases, like compomas are also coming these days.
Hmm.
So is it good for going composites only, or we can switch over to various other restoration things?
Although I could not understand the question much. Um, I mean, the question is first I thought that it is going to come that why did I choose dentistry as my profession? Then I thought, no, this is not the question. The question is that should we using composite or we should switch to other materials? Is this the question? Then it all depends on, I mean, if you want aesthetics, then of course composites. And if you want uh, you want restoring the deep caries lesion, then you have many other materials to go ahead with. I hope that I have understood the question correctly and answered. But really, we have a very inquisitive gathering over here, very inquisitive audience. Thank you so much. It's really nice to have questions.
Thank you so much, ma'am. Really, thank you so much, ma'am. Your lecture was very intriguing, and we would like to listen you more.
Sure.
Ma'am, now I would like to request Dr. Renu Agrawal, ma'am, our professor, to kindly grant a word of thanks.
Thank you so much, ma'am. Good morning,
Thank
one and
you.
all. I hope you have enjoyed the informative webinar conducted today by the ma'am. It's my honor and privilege now to give the vote of thanks to all those who make this event successful. I, Dr. Renu Agrawal, professor in the Department of Conservative and Analytics of the Surendra Dental College, on the behalf of entire organizing team, extend a very hearty thanks to Smita Singh ma'am for sharing her in-depth knowledge and opinion today. She has been my teacher and my motivation from the day one of my graduation. It's long journey, 20 years almost.
Really.
I feel so privileged to have ma'am with us today. Her efforts towards giving us an excellent coverage for the topic are tremendous. So let's just start using the knowledge and experience that ma'am has shared with us for the improvement of the direct composite resin restorations. I would also like to thank the management of Surendra Dental College, Mr. Gaurav Gupta and Mr. Suraj Agarwal sir for their unconditional support for the organization of this event. We are fortunate to be supported by the team of Money, Mr. Rajnish Pandey, Ms. Imam De, Mr. Sivam Shahi for the success of this event. Last but not least, I thank Dr. Neetu Jindal ma'am, our head of department, for her efforts and hard work. I am also grateful to the audience for their attention and the patience listening. Once again, I thank you all for being with us in this morning. Thank you all. I would like to listen. Soumya?
So much, ma'am. Ma'am, we would like to really listen you more, and very often it was very motivating for us as students.
Thank you so much.
Thank you
Thanks
so
a
much,
lot.
ma'am.
And actually, the audience was great. I mean, everyone being there for such a long time, because we had almost, it is going to be good afternoon, because I started my lecture with good afternoon thinking that if you are sleeping, then please do wake up. So the thing is that after a few minutes, it'll be good afternoon. Is it not? So it
Yes,
was
ma'am.
really great to have you all, and I salute uh, the audience, thank you so much. And I would like to really thank Team Money, Ritesh, Shivam, Iman, and all the other team members to have been such a constant pillar of support. Thanks a lot. And of course, my dear friends, my dear audience, thank you so much.
Thank you, ma'am.
And in the end, I would like to thank Surendra Dental College, the staff and the management for giving me this opportunity to be here with all of you. Thank you so much. So should I leave?